Meet Curtis and Diane Williamson. They have a lot in common. They're married, and Curtis is alive today because Diane became a living donor for him. For Diane, becoming a living donor for her husband was a no-brainer, and she didn't wait for him to ask her.
You know, actually, when I first applied, I think I was just not knowing what the process was, a little more nervous. As we got into it and I was approved, or going through the approval process rather, I was more excited than I was nervous. I was ready to move forward with our life, and I thought this was our best option to do that.
Diane wasn't the only option to be a donor for Curtis, but she thought that was the best option.
Curtis has 3 children and I have 2, so it seemed, especially in the beginning, like his family was more excited and mine was more nervous. But as the testing continued, I think even my family got on board and said that they thought this was the best choice for us. Like I said, our kids are raising their families, and even though some of them had offered to try to be donors, we really preferred that I be the one, if it was possible at all.
Curtis was very sick with hepatitis, and Dr. John Roberts, a transplant surgeon at UCSF, said Curtis would probably need a liver transplant.
Well, when I progressively got worse, the doctor said, well, do you have somebody, a family member or friend that would be willing to donate to you? Because it got to the point where it would be, I knew I may need a transplant in the future too. Well, now we really have to start thinking about it. So my wife and I discussed it, and some of the kids, wanted to see if they were eligible. My brother tried to see if he was eligible. He wasn't eligible. And then finally my wife said, I want to try. And I didn't want her to do it at first, because of my concerns for her health. But as I thought about it, if I was in her shoes, I would do it. I would do it for her.
The Williamsons are a lovely couple. Mr. Williamson was actually in the hospital. He was having a problem with his liver, and his wife was by his bedside, and Dr. Roberts went in and talked to them about her being a potential liver donor. He explained things to them and then gave them my contact information to go ahead and talk to me about her being worked up as a potential donor.
For a patient with serious liver disease like Curtis, a transplant was his best option. And as with other liver patients, the choice was between a deceased donor and a living donor. But the competition for a deceased donor is tough.
And no matter how good a job we do, and we take a lot of pride in doing that, we still lose patients on the waiting list because they get sick very quickly and then they become too unstable for transplant. If they come up with live donor at an earlier stage, then maybe we can prevent some of the patients from dying. So we're really seeing patients dying on the waiting list because the demand still far exceeds the supply.
But getting to the top of the list for a deceased liver donor is a risky business.
The ability to get a liver is based on a priority score rather than how long you've been on the waiting list. So the sicker you are, the higher your priority score. And in California, the priority score to get a transplant is usually between 30 and 40. So people that have a score, a priority score, which is called the MELD score of 30, have a survival at 3 months that's probably about 50-50. So about half of the people that with a MELD score of 30 are dead within 3 months.
So there is a catch-22 for liver patients. You have to get sick enough to qualify for a transplant, but if you're too sick, you may not live long enough to get it.
In liver transplantation, really, it's is that the people that are waiting need to get sicker in order to get a transplant, because usually what we're doing is transplanting people that don't have a chance to get a deceased donor transplant unless they were to get a lot sicker. So getting sicker is a problem, because in order to get sicker, that means that your health has to get worse. And of the people that, as they get sicker, what happens in liver disease is that they don't necessarily get a little bit sicker each day. What happens is that they get an infection, or they have bleeding from their stomach, or those, and all of a sudden they're falling off a cliff.
So what is this MELD score that Dr. Roberts talked about?
So the MELD scoring system is the tool that's used to rank patients on the transplant list, and it's comprised of 3 different lab tests currently. One is the bilirubin test, or how yellow the patient is, the clotting time, or INR, which tells how thin the patient's blood is, and then an assessment of their renal function, the creatinine test. Those 3 lab values are determined on a daily basis, potentially, put into a formula, and then a score is calculated, and that will determine where the patient ends up on the waiting list in terms of where they are in the line.
Of course, if you have a living donor, you don't have to wait to get so sick that you get to the top of the deceased donor list. And there are other advantages.
Generally, the outcome following live donor transplant in terms of survival is better for live donor than deceased donor. And that has been looked at quite extensively. The reason why I believe that the outcome of live donor is better is because you generally select the donor with healthy liver, and you generally have patients going through live donor transplant before they become critically ill. So I think those are the 2 main factors.
Getting sick is not a good thing. And the other thing is, when you get sick, is that means that usually you are going to have other problems. You're going to have lost a lot of weight. Your kidneys may not be working so well. You're weak, and so your recovery after transplant tends to be a lot longer than if you were to get a living donor transplant before you had to get sick. So the advantage of living donor transplant really for somebody with liver disease is that they don't have to get sick. They can get a transplant when they're relatively well, as compared to the degree of illness that they would have to develop to get up to the top of the waiting list.
So the recovery time for a living liver recipient generally is a little bit quicker than for a deceased liver recipient, because usually our living donor recipients are in better shape. How long it will take for somebody to recover from a liver transplant in general really depends on how sick they are. And of course, if you're waiting for a deceased donor liver and your MELD score goes very high, chances are you're going to be in the intensive care unit, maybe with kidney failure, and the recovery from that is a lot longer than if you were to get a living donor liver when you're still walking and talking and can come into the hospital in better shape.
Curtis Williamson got that message loud and clear. So he started the process of planning for a living donor transplant and gathering all the information he needed from the transplant staff at UCSF.
I always felt like I was in very good hands. They explained all the risks, and I knew eventually that, at this point, I knew eventually I would need a liver transplant. And if I continued on the deceased donor list, that I would probably get to the point where I may be not healthy enough to survive.
Curtis's wife Diane had volunteered to be the donor, and so it was her turn to find out what was involved in the transplant surgery and to understand what the medical staff needed from her.
Actually, I think their goal is to make sure that this is something you really want to do. They told me all the downside, all the negatives, and wanted to make sure that I knew all the risks that were involved. Every doctor that I met with started with the risks, and it almost felt like they were trying to talk you out of it rather than talk you into it. And I did feel like through the whole process there was no way they were going to put me at any more risk than the actual surgery itself. Through all the testing, through everything that I went through, they wanted to make sure that I was healthy and ready to move forward with the process.
The surgical process for a liver transplant starts with the donor.
It's a very carefully coordinated procedure. Generally, the living donor procedure will start first, The liver is evaluated to make sure the anatomy is correct. The team will begin to split the liver, and at that point the recipient operation is started in the room next door. On the recipient side, their old liver gets removed completely with preservation of the various blood vessels that are needed to connect up the new liver. Once the piece of new liver is removed from the donor, it's flushed of any remaining blood, and then it's ready to be sewn into the recipient.
We take out their old liver and replace it with part of a liver, because that's what we get from the living donor, is part of a liver. And to do that, we have to connect the blood vessels that bring the blood into the liver and allow the blood to get out of the liver, and then we have to hook up the bile duct, the tube that brings the bile out of the liver. We have to reconnect to their digestive tract. And so those are the connections that we make when we do living donor liver transplant, is to reconnect the blood vessels and the bile duct. Now with a living donor liver transplant, we're getting a piece of the liver, and so we're working with the branches of the blood vessels and the branches of the bile duct rather than the trunk of the blood vessels and bile duct.
None of this detailed explanation scared Diane.
There was, at no time did I think they were going to put me at risk at all. In fact, there were times when I felt like saying, it's okay, it's all right. Because they needed the larger portion of my liver, because my husband's an adult male, he needed the larger portion of my liver, and they wanted to make sure that I realized that would leave me the smaller portion, which would add more risks. They took me off separately always. They assured me that if at some point I decided I didn't want to do this, they would make that process even comfortable for me. They said, we will, they would tell my husband or whatever, needed to be done. But they supported me through the whole process.
For Diane and Curtis, finding a living donor was easy because Diane spoke right up and offered to be his donor.
I definitely went to him. He was more apprehensive and saying, I don't think I want you to do this. I'm worried for you. But I was more gung-ho about the process.
Of course, it's not always that easy. Suppose you don't have a spouse who can be a donor. How do you begin the process of finding someone who could be your living donor?
It's a difficult thing for recipients to ask potential donors, and we can give them a little bit of advice when they go through the evaluation process. The system that's going to work for any given patient really depends on who they're trying to target for potential donors. Certainly some newer innovations to get the word out involve using social networks, churches, for instance, other modes to spread the word around your people that surround you to get information about potential donation and potentially find a donor.
And sometimes we advise the patient to use a mailing or email or social media to discuss the situation, so that you present to a large group of friends, relatives, and so forth. So it doesn't really put direct pressure on who may come forward, but it's purely voluntary and there's no pressure. So this is kind of the way that we encourage patients to go about doing it.
The thing that we try and let them know is that we understand it's difficult, but if there's somebody who's interested in helping you out, don't feel like you have to go ahead and make that decision for them, or that you have to explain the process to them. If they express any interest, give them our number, that they call us and we can provide the information to them. I reassure the recipient that it's not like we're going to hold the donor and say, you've got to do it, you've expressed an interest. There's none of that at all.
As Ana Marie Torres says, there is some risk to being a donor, but it is a small risk. And the paramount interest of the transplant team here is the health and well-being of the donor.
Our first concern is for the donor, because they obviously don't need this operation. It's not going to help them in their health, and we don't want to put them at risk in order for them to donate. So we know that donating an organ, there is risk associated, but we want to make sure that risk is as small as possible. So what we do is we evaluate the donor, make sure that they're healthy, that they don't have diseases such as diabetes, hypertension, liver disease, those things that could prevent them from being a healthy donor.
The good news for a liver donor is that you only donate part of your liver and it will grow back.
You know, liver is an amazing organ. Okay, it can regenerate very quickly. So if you remove, say, 40 or 50%, you know, the remaining portion of the liver can grow very quickly to close to 90% of the original volume over a period of about 6 to 8 weeks. So the regeneration is extremely quick. So liver is an amazing organ for a live donor transplant.
While being a living donor mainly benefits the recipient, there are some ways in which the donor can get financial assistance.
The acceptable things are, one is to cover travel expenses, two, to cover subsistence expenses relating to the donation, so covering a hotel room or food or those kinds of things, and then the recipient could cover, say, lost wages, so that if they lost wages in terms of during that time off of work, then that would be, the recipient could do that.
There are also national programs that help cover expenses for a donor.
I have access to a wonderful program called the National Living Donor Assistance Center, and they provide travel-related expenses. So they'll pay for things like flights and travel-related expenses for donors and a loved one to accompany them.
Besides covering travel expenses, the donor's medical expenses are also covered.
Evaluation of the donor and the operation are paid for by the recipient's insurance, so that the recipient's insurance, takes care of all those expenses related to donation. For people that have donated, usually if they have some trouble related to the operation within a year, the transplant center has the ability to pay for those complications.
There is an online portal to help potential donors get information about the donation process and to figure out how to get started. It's called the Breeze system.
So to facilitate patients' access to our system, we have an online program where patients can get through the initial questionnaires that we need to begin to evaluate their medical condition. And this Breeze system is used both for donors and recipients to enter basic health information, which our program can then quickly review and determine if a donor can move forward or if a recipient is appropriate for evaluation in our program.
So this is a online health history questionnaire. And so if I would tell the patient, the recipient, that the donor can go on this website. It's a questionnaire so that they provide demographic information and a little bit of a health history. So that initiated this process and is reviewed by Dr. Roberts and his team. So some potential donors get accepted after they pass this screening process. Some get turned down because that person is not healthy or other factors, say age and other factors.
So in the Breeze evaluation, a potential donor will be asked some general questions about their height and weight, their habits, do they smoke, and then general health conditions, making sure they don't have diabetes or high blood pressure. There'll be some quick questions about medications, although most donors usually aren't on a lot of medications. And then past history about previous surgery or other medical conditions are all evaluated in the initial Breeze intake form.
So you've identified a potential donor, and you're both ready to move ahead with the procedure. What's it going to be like? Curtis and Diane have been there.
I thought that at some point I would become more nervous than excited, and for me that never happened. We got to the hospital and checked in, and were told that our surgery would be first thing the following morning. I thought I would be going down to the pre-op first, and they called, and Curtis was actually taken to pre-op before me, and then we were, when I went down, we were taken to the same room, so that was nice. And we had all of our children down there with us, so like I said, I think we were more excited than we were nervous even up till that point, and I would have told you that at that point I would have been more nervous.
When I woke up the next day, my first concern was, I know I had surgery, So I know the surgery had occurred, but I was concerned about my wife, so that was the first thing I said. And when I first woke up, I had a breathing tube still, so I couldn't talk. So I motioned to the nurse that I needed something to write on so I could ask about my wife. And finally they figured out what I was trying to say. And they said, "Oh, your wife's doing just fine." So I was relieved at that.
I had a very easy time. Our surgery was on Friday morning. By Sunday morning, I told them I didn't want any more of the pain medication. I didn't like the way it was making me drowsy. When people would come in and talk to you, and I couldn't even keep my eyes open. And they let me know that the medication would be there if I needed it, and I never needed it after that point. I had discomfort, but I wouldn't say pain.
When we spoke with Diane and Curtis, it was just 3 months after their surgery, and the news could not have been better.
We're doing great. I think in the beginning I was recuperating faster, which was a little frustrating for my husband, but he had to go into the process. I went into the process fine. He went in being a pretty sick guy in the beginning. So I feel like I recuperated pretty fast. I was tired a lot in the beginning, and that was the main thing. Fatigue. I'd walk to the mailbox and back and feel tired and be a little frustrated with myself for that. But as far as not being able to, function, I felt like we were able to function on our own fairly quickly after the surgery.
Oh, I feel great. I feel like I can think clearer. I'm not cloudy, before I was a little cloudy and hazy. I'm not retaining fluid any longer. I don't have to take any of those medications.
So we know how the patients feel about the value of being and having a living donor. What about the UCSF transplant team?
It's important to have the live donor program because it's a way of offering some of our recipients an opportunity to be transplanted sooner rather than later. They can go ahead and wait on the list, but there's no guarantee that they're going to receive a transplant, and that when they receive it, that their recovery time might be a little longer. If they go through a live donor transplant, they can get their transplant sooner, and their quality of life improves right after they receive their transplant.
Well, as a transplant surgeon and seeing patients who have to go through the long wait to get their deceased donor organs, I'm always quite surprised when the family shows up at the time of transplant and are all wondering why their recipient has gotten so sick and why it's been so hard for them to come through the transplant. And I think if potential donors and recipients really think carefully about the impact on their health of waiting a long time for organs, they'll come to realize that it makes good sense to try and get a transplant done as early in their disease process as possible when they're still in much better health. Because the transplant, if it's successful, which it is most times, will preserve their health at that point and avoid the deterioration that comes as patients have to wait long times for a deceased donor.
I've been in the liver transplant service for a long time. And one thing that really makes me think is that we're trying to do as good a job taking care of very sick liver patients as possible. And over time, we realize that we're transplanting patients become sicker and sicker. They have to wait longer until they become so ill to be at the top of the waiting list. That really convinced me that live donor transplant is the way to go.
And these two people could not agree more.
Knowing how easy it was for me, and I don't want to pretend that it's the same for every person because I don't know, but I would definitely hope that more people would offer to donate. I feel like I'm back to where I was.
Not to worry, because you could really worry about this for a long time. And the doctors, the nursing staff, even the radiologists at the hospital, they're so reassuring and comforting. That helped the whole process for me.
Having gone through this, I wish more people would. A lot of people don't make it until they get a deceased donor offer because they've gotten too ill. And we were very fortunate that before my husband got too sick, I was able to donate. He had a much better chance for recovery, and I think that's why he's done so well.
The process wasn't as bad as you may think. You may think it's really bad and you might not survive and, oh, it's just horrible. But if you can just think about the good that's going to happen out of it, how much better you're going to feel, how your whole family benefits from this, you'll be able to make it just fine.
Certainly.
Sure.
Absolutely. Well, I mean, I think if it was for like a close family member, I would be like, I would do it in a second.
I think if there's an opportunity to help someone, that doesn't seem like a huge cost. So
it's family. You just go and help your family, and particularly if it was one of my kids, absolutely.
It's not something I'd rule out, but it's honestly somebody's never asked me the question.
I would consider part of my liver, and I would think about my kidney. Yeah, I would.
I mean, I think it's scary, right, to have, invasive surgery of that type, but, your family or friend, like, it seems like it's the right thing to do, and I would do it.
Well, you want to help prolong the life of somebody who's either family or friend, and hope that they have a better life than what they're experiencing at that moment.
That's my family. It's very important to my family, right? And important to me.
I think it's, just the value of human life and understanding that if you can give someone the gift of life after the fact and they've had it and they value it, I think it's something that my morals and my upbringing would have taught me that I should do.